Hey guys, thanks for checking out my channel, One Page Medical. My name's student Dr. Todd. I'm a fourth year medical student, currently applying anesthesia. I'll figure out where I match or if I match in 90 days. So very excited about that. But I decided to make some educational content during the second half of fourth year, trying to get myself to review some of the basics, anatomy, physiology, big ticket items that are going to be very helpful for me in intern year. I'm making these videos just for myself. It gives me something to do. It gives me a reason to kind of relook at material. Plus, it's fun to do. I'm not trying to be YouTube famous or anything, but I figured if I'm going to make them, I might as well put them online and, open myself up to ridicule, as it were. I'm not trying to be YouTube famous. If you do stumble across this and watch it, feel free to comment if I mess anything up or you have any suggestions. Feel free to share it. I'm not trying to make any money off this. I'm really just doing this for me. So with that said, I'm gonna dive into my first video, and I want to start off with the cardiovascular system, just because that's a real big hitter when you're taking care of patients in the hospital, because a lot of Americans have cardiovascular issues. So we'll start off with just external cardiac anatomy, and my plan for this page and for these videos is to break things down so I'm never presenting on anything more than 10 or 15 minutes, and whatever topic it's going to be is going to fit on one sheet of paper or less. That way you don't, have to scroll through 3 hours of videos on all of cardiac physiology, and it kind of trims the fat and gets at what's most important or what I've seen, be asked on, rounds, or, getting pimped on questions and all that kind of stuff. So without further ado, let's get going. All right, so let's get started with our first video here on external cardiac anatomy. One thing that I really, really learned in med school is that I wasn't as smart as I thought I was. I think it's a pretty common realization for a lot of people when they get into med school, because med school is very hard. And you have a lot of material to learn. So really, for me, when I was learning things or am still trying to learn things, I really like to try to dumb it down as much as possible, right? Think about the easiest way to learn something, the most simplistic way, and that way it's easier to recall, it's easier to get stuck in your head, and you're not having to sift through the details and minutia of whatever the subject matter may be. So when I'm learning about the heart, the easiest and most dumbed down way to think about it is as a pump, right? And when you have a pump, whether it's pumping blood or pumping water, the easiest way to look at that system is to follow whatever substance it's pumping. So in the heart's case, it's blood. So let's follow the blood, right? And that'll also help us have a good flow to talk about these structures. Flow, get it? Flow, blood flow. I'm a new dad. I'm practicing. Okay, so we have blood from the systemic venous circulation, right? That's passed through the capillaries. It's coming back to the heart, right? And we have, stuff from like the head and neck coming down the superior vena cava, and stuff from the, lower extremities coming up from the inferior vena cava. And both of those are dumping into this right atrium, right? So it's deoxygenated blood going into the right atrium. From the right atrium, that blood is going to flow through what's going to be the tricuspid valve, and the tricuspid valve is going to connect the right atrium to the right ventricles. And again, we'll go over all these external coronary arteries and stuff in a little bit, but let's just do the major structures, right? So you have right atrium, tricuspid valve, right ventricle, right? And then the right ventricle is going to squeeze, and the right ventricle is going to be responsible for pushing the blood into the pulmonary vasculature, okay? So the pulmonary vasculature, to get to the pulmonary vasculature, you have to pass through the pulmonary valve, which will be in here, and then out the right ventricular outflow tract into the right and left pulmonary arteries. Again, though, remember, they're arteries, but they're still deoxygenated. They're going to the lungs to oxygenate the blood. So an artery is just something that moves away from the heart. It doesn't matter if it's oxygenated or deoxygenated. It just turns out that most arteries are full of oxygenated blood, except for this one, okay? Or, well, both of them. So we're in the pulmonary system. We get our blood oxygenated. Our blood's full and juicy with that oxygen. Now what's going on? So that, oxygenated, beautiful, bright red blood is then going to get pumped back into the left atrium. And then that is getting returned by these left and right pulmonary veins. Again, most of the time veins are deoxygenated, but because it's coming back to the heart, it's still a vein. And it's the pulmonary vein, right? Which makes sense. Comes from the lungs, it just got oxygenated, now it's in the left atria. So we have this left atria here, and then in between the left atria and the left ventricle, we have the mitral valve. Okay, so blood's going to go through that mitral valve. It's going to go into this left ventricle, which is the biggest ventricle of the heart, right? It's the one that's responsible for much of the forward pressure gradient that propels the blood to the rest of the systemic circulation. So with the contraction of this left ventricle, the blood is then going to flow up and out. What would be here is the aortic valve into the aortic outflow tract and then through the aortic arch, right? So you have the ascending aortic arch and then descending aorta. Knowing those structures is important when you start thinking about things like dissections, type A, type B, things like that. And then also, cortication of the aorta, where is, which is, narrowing of that aortic arch. And where it's narrowed would affect what structures, are seeing increased blood pressures, right? So knowing what's coming off of this aortic arch is also very important. And the main three that you need to know are the brachiocephalic, the left common carotid, and the left subclavian. Now, the reason there's not a right common carotid and a right subclavian is because the brachiocephalic branches off into the right common carotid and the left subclavian. However, there's no left brachiocephalic, okay? So that's a big distinction between right and left-sided structures as far as that aortic arch extravasculature is concerned, okay? So, great. We talked about where the blood flows. It's in the body. Everything's groovy. But how does the heart itself get its blood supply, right? How does it deal with its oxygenated blood, its deoxygenated blood, all that kind of stuff? I'm glad you asked. What happens is the heart is perfused during diastole. So there's back pressure that's going to be felt in this aortic area, and then that's going to perfuse these coronary arteries, right? And it's going to push that freshly oxygenated blood that just left the aorta, it's going to push it back into the coronary vasculature, arterial supply. So, some important ones, right? Up here, these both come off of the aortic arch, right? We just said that. Pushes out of the aorta. So, you have your right coronary artery and your left coronary artery, okay? This is important because the left coronary artery really supplies most of the heart. Its most typical hearts are left dominant circulation, right? There is variation, there is right dominant, there's co-dominant circulation, but the ones that you're going to get tested on and the one that you'd expect to know as a med student is just the boilerplate left dominant circulation. So that's what's kind of demonstrated here. So you have this kind of bigger left coronary artery, and then you have your right coronary artery. The right coronary artery, while though smaller, is still very important. Mainly because it, obviously supplies blood to the right side of the heart, but it also supplies blood to the inferior part of the heart. And it and supplies blood to something that is also very important, which is the SA node. So you have your right coronary artery. Off that, you have your SA nodal artery, which is kind of right here. And then you're going to have your right coronary artery, and it's going to kind of loop around, and we'll talk about the backside here. So that's kind of does it for that right coronary artery on the front side. What about the left coronary artery? Again, coming off the aorta, it's going to sneak behind those pulmonary arteries, and it's going to branch into the left anterior descending artery, or the LAD. And then it's also going to swoop around kind of the back of the heart, just like we see here, and that's going to be the left circumflex artery. Okay, so the left circumflex artery kind of comes around, and then the left anterior descending kind of comes in and lays between this intraventricular groove, right? And the LAD supplies the intraventricular septum, right? And knowing your coronary artery supply comes in handy, because when you're getting asked questions about, ischemic heart damage, and then you're given a patient with certain signs and symptoms, based on what their signs and symptoms are, how long it's been from their last ischemic event, you can, make a good guesstimation on what structures might be damaged, right? So we'll get into that more with internal anatomy and, when we talk about MIs and acute coronary syndromes. Okay, so that kind of takes care of it from the front side. One thing they do really like to ask about, and I've seen it on a few board questions, is they'll give you a vignette and they'll say like, hey, taking care of a trauma patient, he got stabbed right in the chest, on the left side. What structure is, most likely damaged of the heart? And the answer that they're looking for is the right ventricle, because as you can see, the way that the heart sits in the body, the right ventricle is most anterior. Okay, and that's just something that they want you to know, and they want you to know how the heart sits in the body. So take that nugget, and then when you get the UWorld question right, thank me. Okay, so now we're going to kind of rotate, and we're going to look at the backside of the heart. Right, so we still have all of these structures. You can kind of see the backside. There's the aortic arch, subclavian, common carotid, left subclavian, or brachiocephalic. I mean, these are your superior inferior vena cava. This is your pulmonary arteries, and then here are those pulmonary veins, right? And these are the pulmonary veins. This is just showing you that it does indeed drain into the left atrium, right? So again, let's follow the blood. Blood comes in the superior inferior vena cava into the right atrium through the tricuspid valve into what is now the right ventricle. Right ventricle is going to pump blood out into the pulmonary arteries. It's going to get oxygenated. It's going to come back into the left atria. It's going to go down through the mitral valve into this big, chunky left ventricle. That's going to contract. It's going to go through the aortic valve into the ascending aorta and aortic arch and out to the body. Okay, so same structures, just flipped around. So the reason I wanted to show you the back side of the heart is because of what we were talking about with some of the blood supply, and then I also wanted to show you this really important structure right here. So this is called the coronary sinus, right? And so all of this vasculature, right, or all of this venous return, it doesn't go back into like some other vein and then dump into the IVC or the SVC. No, it dumps into kind of its own thing, this kind of chunky coronary sinus, and that dumps right into the right atria. Okay, so you have all of the deoxygenated blood that the heart used dumping right back into that right atria. The reason I like to point this out is because this is, when you're doing like an open heart case or you go on bypass, they do something called cardioplegia, which is where they give like an epic dose of potassium and they cool the heart in order to stop it so they can operate on it. And you can either go retrograde or anterograde. So retrograde is backwards. So instead of going, the forward route, which would be introducing cardioplegia through the arterial system, you go retrograde, and that would be introducing it into the coronary sinus. And that can then stop the heart and they can work on it and then they restart it. It's very cool. Highly recommend you try scrubbing in on a open heart case if you ever get the chance. One of the coolest things I did in med school for sure. Um, okay, so other than that, you have your left circumflex artery again coming here, and that's showing you it's kind of just covering this side, but more on the back. And then you have your right coronary artery. Okay, this is your posterior descending artery. Okay, and then as you can see, the right coronary artery comes down and branches of its supply the inferior part of the heart. Okay, so that's why when we get into EKGs, if you see ST elevation in lead 2, 3, or AVF, it's an inferior MI, and then the question will be, what vessel is occluded? And it's going to be, okay, there's obviously an occlusion in the right coronary artery because it's inferior, and that's what supplies that region. So learning anatomy has its purposes. It's not just for show. And then the last thing that I want to talk about is this left atrium. So the left atrium is the most posterior structure, right? Right ventricle most anterior, left atrium is most posterior. So the esophagus is running down right here. The reason that is important is because when they do something called a transesophageal echocardiogram, or a TEE, they're really feeding an ultrasound probe down into the esophagus and then pointing that camera at different angles and looking at all of the internal structures of the heart and how the heart's pumping and functioning. And it's a really, really good for looking at the valvular structures, much better than the transthoracic echo. So why is that important? Basically, they'll give you some type of vignette and a question, and they'll be asking you about TEE and what's the best valve to check out with it. And you're going to want to say the mitral valve, right? Because the left atria is the most posterior. That means it's closest to the esophagus. And then the valve that's closest to that is going to be the mitral valve. So that you're going to get the best picture of the mitral valve by doing a TEE, a transesophageal echocardiogram. All right, guys. Well, that was my first official video on external cardiac anatomy. Hopefully, you got something out of that. I know that I definitely got something out of it, just, learning how to draw a heart properly for the first time. And I will say that, when you're learning anatomy, it's very, very helpful to be able to draw things out, even simplistically. I am by no means an artist, as you can very much tell from the work that was just presented to you. But just being able to kind of like freehand sketch a simple diagram of, the organ system that you're studying or anything like that, it's really beneficial for your studying in the long term. And it's really going to help it seal it in there. And it's not Anki, so you're not going to be, smashing a keyboard for the next 4 hours. It'll give you a little bit of something to break up the monotony of what studying for med school can really feel like. So again, I hope you guys got something out of that. Again, feel free to give me feedback. I'm definitely open to it. Our next one is going to be internal cardiac anatomy, and then kind of the basics of the electrical conduction system of the heart. And then from there, we'll move on to more physiology, pathophysiology, pharmacology, and then specific disease managements. And all those will be broken up into short 10, 15-minute videos, similar to the ones that you just saw today. So if this is your jam, thanks for checking it out, and hopefully see you next time.